Okay. All right. So hopefully everyone is in the waiting room now, not out of the waiting room, sorry, now into the webinar. Apologies for the delay. We're having a little bit of technical difficulty this side, but anyway, it's sorted. So I'd like to introduce Ruth Stanley, who is an advanced lead pediatric dietitian working in gastroenterology at the Great North Children's Hospital in Newcastle, based in the north of England. She's part of the core blended diet group for the BDA, which produced the blended diet toolkit. She's also facilitated the implementation of blended diet provision in Newcastle. So this is the second part of our blended diet series. The first one was a couple of weeks ago where we looked at sort of blended diet in the community setting. So hopefully this will answer some of those questions around setting up those services in the hospital setting. All right, over to you, Ruth.
Thank you. Right, let me just share my screen. Oh, it's not letting me share my screen at the moment.
Let me see, am I the host? Okay, see if that works. Perfect.
Okay, can you see that?
Yep, it's just loading. There we go. Oh, yeah, perfect.
Has that worked, yeah?
It has, yes.
Okay, right. Not very good with technical things, sorry. Okay, so thanks Lucy for the intro and also for asking me to come and speak this evening. So as Lucy said, I'm hoping to draw on my experience and also some of the recent evidence to discuss how blends could be established in a hospital setting. So this is what I'm hoping to cover by the end of the session. So I thought if we just did a little bit of background to start off with, I don't think many of us, or I'm hoping not many of us, are strangers to the concept of blended diet. And many working groups have defined blended diet, and this is ESPGHAN's here. And essentially it's where food and drink is blended and given through an enteral feeding device. This can range from someone receiving a small amount of puree or juice alongside enteral formulas to them having all of the nutrition met through a blended diet. The use of blended diets is becoming increasingly popular, and expert consensus statements have been produced, and here's a list of some of them. These can provide guidance for healthcare professionals on how to support patients on blends. The majority of these consensus statements mainly focus on community-based patients, but as we've all probably experienced, patients requiring blends often have complex needs, which usually means at some point they will require admission to hospital. So this poses a question. When admitted to hospital, can or should patients continue on a blended diet? To try and answer those questions, I think we probably need to look at what some of the evidence says, and there's loads out there, and this is literally just touching the tip of the iceberg. So should patients have blends in hospital? You could argue that with multiple commercial enteral formulas readily available, many which cater for specific conditions, they probably aren't. But there are some key considerations. The increase in popularity, as I've already said, means that there is an increased chance that the patients receiving blends in the community will need to access acute services, and this will therefore place a demand on hospitals to provide blended diet. A recent UK national survey found that 41% of dietitians reported 1 to 5 children per month being admitted on blended diets. And this was the same for whether it was a community hospital or a tertiary regional hospital. Reports of blended diet improving symptoms such as reflux, vomiting, and diarrhea has led to it being suggested and almost used as a treatment for some people. There is therefore an argument that the use of blends could lead to reduced bed days. I've experienced this multiple times when patients have come in with poor feed tolerance. I've started them on blends and actually they're much better and able to go home. A paper published in 2011 actually describes the positive effects of blends on patients who'd undergone a fundoplication. Improved patient satisfaction has also been reported by US hospitals providing blended diets to inpatients. And similarly, the Royal Hospital for Children in Glasgow also found that blends improved patient health and well-being and reduced stress and anxiety for parents. So what about, can blends be provided in hospitals? Well, the early evidence around provision of blends in hospitals was often quite negative, and there was a lack of strong reasoning to why. But there is emerging evidence being published with examples of successful implementation of blends across places like Scotland and America. In papers that do discuss blended diets being implemented successfully, a running theme throughout is the requirement to ensure adequate processes, policies, and guidelines are in place in the hospital or trust to ensure blended diets can be provided safely. A UK national survey this year found that only 49% of hospitals had clinical guidelines for managing these patients. So, if you are wanting to set up blends in your hospital or acute service, where do you actually start? Well, I can appreciate the prospect of providing blends in different care settings can be really challenging and daunting. However, consensus statements and guidelines really encourage clinicians to try and overcome these and assess if it is feasible to implement blends in their care settings. I think it's really important to stress, though, that the final decision for implementation of blended diets lies with the individual care providers. If you do come up against any barriers, it's useful to explore these. A paper looking into blended diet provision in an American hospitals detailed that the Mayo Clinic had suspected blended diets were being used for some time, and therefore, before dedicating resources and time to developing patient information and guidelines, they measured the incidence of use. What they found was that 55% of their 2,000 tube-fed cohort reported using some form of blended diet. They reported that due to the high number, management agreed to blended diet resource development. Now, your numbers of tube-fed individuals may not be as high as the Mayo Clinic, and I know that ours definitely isn't, but this may be a good benchmarking exercise to assess feasibility. To implement and support blended diets, collaborations with different teams and individuals within the trust setting is extremely beneficial. All hospitals and trusts have different processes, stakeholders, and departments, and therefore everyone will experience slightly different things. You may find setting up a working group is beneficial to help make decisions and share workload, and I would suggest this would be a good place to start. In Newcastle, we've had 2 short life working groups for blended diets. The first group, which consisted of dietitians, gastroenterologists, and a specialist nurse, was formed before any national guidelines existed, and it was when blends were still quite a controversial topic. We engaged with hospitals, committees such as medical devices and nutrition steering and infection control to explain why we wanted to allow blends within the hospital and the benefits it could bring. As we are also a regional specialist hospital, we also consulted with local dietitians and departments to ensure that they were happy with what we were saying and proposing, and so that we were ensuring that the same messages were being provided to patients as well. Later on, we formed a second group to establish the review of the trust guidelines. So this is when the BDA new guidelines had come out. And this one included dietitians, community nurses, and clinical nurse educators as well. The benefit of all these collaborations is providing you with support and guidance, but it also allows key aspects of blended diet provision and administration to be agreed upon across the board, such as, are nurses able to administer blended diets? What paperwork, if any, needs to be completed or seen before blended diet could be administered? So, you set up your working group. So what's your next step? As I've mentioned quite a few times, the key to successfully implementing blended diets in hospitals is a clear and comprehensive guideline. But ironically, this is also one of the main challenges and barriers as well. I think knowing where to start or what even to include in this is a really daunting task. From my experience, and as suggested in consensus statements, the following points may be of benefit to consider when devising your policy. And I'll talk about some of these points in more detail as I go on as well. So, who is the policy for is a really key thing, as this will affect the wording of key aspects and pathways. So, for example, in Newcastle, the guideline was updated to cover all patients, including adults acute and community settings. In the guideline, it was agreed that staff were not to administer blends that hadn't been supplied by the trust. As community nurses are also part of our trust and work in special schools, this actually had an impact on how they could train staff and parents in the community. We therefore needed to make sure the wording was very clear, and we also had to consider how training would still go ahead for the community nurses. It sounds obvious, but ensure all aspects of blended diets are covered, not just the provision or administration. ESPGHAN advises that hospitals and healthcare providers should develop clear protocols for blended diet use, covering the points here, which are food safety, nutritional adequacy, tube patency and viscosity management, staff training and documentation. And this is also supported by the BDA and ASPEN guidelines as well. Standardizing each step and process and thinking about pathways, such as what happens when someone is admitted on a blended diet, how to request and provide blended diets as well. It may also be beneficial to document responsibilities of each person involved in the processes, such as nurses, doctors, dietitians, and patients or carers. So, for example, nursing and medical staff are responsible for informing a dietitian if a patient has been admitted on a blended diet. Nursing staff order meals unless a patient has a specialized diet, in which case it's then the dietitian's responsibility. And then dietitians are also responsible for ensuring nutritional adequacy and documenting feed plans. You also want to consider whether or not it's suitable for all settings or medical situations. Would you want to give a large blended diet bolus to a patient admitted with respiratory issues, or even if the patient is requiring continuous feeds? And I'll talk about this a bit more in the next slide. And finally, maybe consider how the provision of blended diets will be in line with other trust policies and guidelines, such as the food hygiene and enteral feeding policy. So, as I said before, blended diets might not always be suitable during a patient's entire hospital stay. So, ongoing individual assessment is essential. This can sometimes cause anxiety for families, especially as there's a history of negative experiences with formula. What I found often helps is open and honest conversations and reassurance that as soon as the patient is able to, they'll return to a blended diet. And this can sometimes help to reduce the stress associated and to build trust as well. It is advised that by informing families about this before a planned admission can also help to prepare them for these situations, and therefore it might be useful to include in any relevant written patient information that you give. So, in what circumstances should we exercise caution or reconsider the use of blended feeds? So the first thing to think about is the type of feeding device, and this is a really important one. So in general, the literature and evidence is focused on the provision of blends through a gastric feeding device, and it's normally recommended using a button. But what about other tubes such as NG or even post-pyloric feeding? So blended diets through an NG can be a slightly contentious issue. I'm aware that they have been given successfully through NGs, and ESPGHAN consensus is not necessarily a negative one towards them. It just simply says that blends may be harder to give through an NG. But in Newcastle, we don't allow blends through an NG. And this is due to concerns when we were starting our blended diet journey from a number of different clinicians, and that it posed a risk to patients. So what they were concerned about was that NGs are longer and thinner than gastrostomies, and therefore a higher pressure is required to deliver the blend, which may result in the splitting of the tube. The concern with this is that you don't always know where this tube might split, and if it's above the epiglottis, then aspiration could occur. This has also been supported by a study published in 2019 by Mundy et al. As well. I therefore feel the use of NG tubes need to be considered by each trust individually and see what everyone feels comfortable with. And again, this is where your working group would come into use. So coming on to post-pyloric feeding. Although there is no absolute prevention of blends via a JEG, it's not routinely recommended due to the safety and practical concerns, although there is, again, anecdotal reports of patients receiving blends post-pyloric. Jejunal feeds do introduce extra challenges, though, that need to be considered. So things like the tube size, like in an NG, they are often narrower than a gastrostomy and can lead to a higher risk of clogging. Continuous feeding is also required with jejunal tubes, and this is not normally recommended for blends. So during my experience in Newcastle, blends into the jej is not allowed, but if a patient's got a gastrojejunal tube in place, we will still allow blends to be given through the gastric port, and I've got lots of patients in the community that have this successfully. So talking about jejunal feeding regimes and continuous feeds kind of bring us on to the type of feeding regimes as well. So if a patient's on a continuous feed or small frequent boluses, so such as 2 to 3 hourly feeds, blended diets is probably not suitable for the following reasons. So if on a continuous feed, a pump will probably need to be used, and blends aren't encouraged to be given through a pump, although there are now pumps available that specifically cater for blends, although we haven't got them in our trust. You also need to think about the hanging times of the blends as well. Would you want to eat a meal that had been sat at room temperature for a few hours? Probably not. Also, from a practical point of view, you need to think, is it possible to provide nutritionally complete blends every few hours? I know that in our hospital, it really isn't. Thinking about the location of the patient is also important. So the current consensus statements do not support routine use of blended diets in critical care. They recommend commercial enteral formulas as the safest and most effective option. Blended diets may be considered only in exceptional cases with strict protocols and multidisciplinary oversight. We have managed to provide blends to patients in PICU, and we've also managed it on our bone marrow transplant unit as well. But this has been when the patients become a lot more stable. And so therefore, what we've actually put into our guidelines is that patients on these wards will need to be considered individually each time. In our first draft of those guidelines, we had put down that they weren't to be provided. And when I went and spoke to PICU about it, they felt that this wasn't a fair thing to put in. So we've covered processes and governance, but let's now focus on how to provide blends in practice. So, as I've already mentioned, it's been identified that perceived barriers to provision of blended diets in hospital are kitchen processes, staffing hours, and food safety concerns. Working groups are great for coming up with ways to address these barriers. There's a bit of a theme going along here about the working groups. The key aspects to consider are how to reduce microbial contamination at each step. So food hygiene has long been a concern when adopting blended diets. Early studies reported high contamination levels with blends, but these were often conducted in low and middle income countries, characterized by elevated ambient temperatures, and in contexts where infrastructure limitations may affect water quality and food safety practices. More recent research shows that with sensible recipes and strict food safety standards, blends can be provided safely in clinical settings. It is important to remember that blends are not sterile, and contamination can occur at multiple points of food prep, handling, and administration. And therefore, it's beneficial to involve infection control and catering departments at the decision-making stage of how blended diets can be provided. If any aspect of the blended diet needs to be prepared at ward level, you need to think about how you're going to clean the equipment in line with trust guidelines. So for example, if you're using a blender on the ward, is it able to be put in the dishwasher to be sanitized and fully cleaned? And if not, how is this going to be cleaned effectively? From experience, having a test run of your proposed process is useful before implementing fully. You often find things that you hadn't thought of along the way, and you may find that actually something that you think is going to work really does not. Okay, so to try and determine the most appropriate method of food provision for your hospital, it's essential to understand the required consistency of a blended diet to ensure that they are still appropriate for administration. In my opinion, I think consistency can be a subjective area. And so what I want to do is quickly go over this as well. So the most important point is that food needs to be a smooth consistency. ESPGHAN suggests to aim for the viscosity to be an IDSI level 1 to 3. So level 1, as you can see on the diagram here, is slightly thick, and level 3 is moderately thick. But what does that actually mean in real terms? So level 1 is similar to anti-regurgitation infant formulas, and level 3 is similar to your first infant foods, so things like a runny rice cereal or runny pureed fruit. A good way of knowing if the blend is suitable consistency is that you should be able to draw the blend up through a 60 ml syringe smoothly. You should also easily be able to administer through an extension set without using a lot of force. If this isn't the case, then the blends probably need to be diluted or either blended further. You might want to consider how to get some practical experience. So try drawing blends up in your office or home, or you could watch online videos, and lots of companies have now produced these to help. So, providing blended diets in hospital can be done by a number of different methods, and depending on your catering systems will determine on which one you want to use. Each method's got its pros and cons, but it's a really quick overview of some of the main methods here. So, using an existing hospital puree menu. So this is where there's already an existing suitable menu to provide your food. And depending on which level is available in the hospital, you might need to blend or dilute the food further. And depending on your catering systems will also determine where or how the blend is diluted. So in Newcastle, this is the one that we actually use. We only have IDSI level 4 puree meals to order from. And this obviously isn't the desired consistency. So what we end up doing is watering it down at ward level. And Glasgow Children's Hospital published a paper on introducing blended diets in an acute setting, and they also used this method. They also used level 3 as well, but what they found was there wasn't a big enough range of foods suitable for their patients just using the IDSI level 3. So they also started using the IDSI level 4 and watering this down. An advantage of this method is the availability of nutritional information as well as the allergen information, and often you can get a fairly good variety of meals available. But these meals are usually developed for adult patients, and therefore I would recommend to check the nutritional suitability if you're using them for children. And another point to bear in mind is that when we implemented it in Newcastle, what we found was that not all the meals were suitable to use via gastrostomy once they'd been diluted from a texture point of view. So we ended up spending quite a few sessions in catering, developing a list of meals that were fine once they've been diluted. And then what we also did to ensure that the consistency was still correct was to repeat it on the ward once the food had been cooked as well, just because there was slightly different textures. So the second method is using a commercial baby food. And this method is widely used, and I often use it for patients just starting out on blended diet, as I think it helps them understand the consistencies that are required, and it reduces down some of the stress as well. So you use a jar or pouch or baby food, some of them might need slightly diluting down, and administer it. In a hospital setting, this comes with a lot of advantages. So the consistency is often the same, so it reduces the risk of blockages. It doesn't require as much work as some of the other methods. And again, the nutritional content is easy to come by. They're also obviously marketed for children as well. But one of the disadvantages I found is that baby food method is that they're not really very high in calories, and I often really struggle to meet requirements. The third one is looking at hospital kitchen, producing blends from scratch. So a dietitian would produce a recipe, often with input from parents or patients, and then it's made in the hospital kitchens. I'd love to be able to implement this in my hospital, and I've explored it quite a few times. I've even managed on occasion to get a recipe made on an individual basis, but I found this to be a lot more complicated than the other methods due to our catering processes. So what I found was that the recipe might be fine down in the kitchens when it was made, but then it would be sent up to the wards and reheated, and the consistency wasn't okay. And then the final one is parents or carers bringing their own blend in from home. I think on the surface, this is probably one of the more convenient options for hospitals and patients or carers. and they may feel more comfortable with it, as the patient and carers are often more experienced in producing blends. But there are some crucial aspects that you do really need to consider. If blends are being brought in from home, it's important to think about how these are being stored, transported, and reheated and disposed of from a microbial point of view. This will need to be in line with other hospital policies or guidelines, such as the food hygiene policy. A key point to bear in mind is that some families may struggle to provide a blended diet from home, as it increases their time away from the child. I also think it's especially so in a pediatric setting, and even more so in a regional setting where patients can often live miles away. If blends are being brought in from home, who's allowed to administer them? Is it only patients or carers? Or can carers and ward staff also administer them? So in Newcastle, staff are only allowed to administer blends provided by the trust. And this is because it was then in line with some of our other policies that we had in place already. We suggested that if a patient or carer are using their own blends and are unable to administer it, then an alternative method or blend would be found for them. One of the key points that I want to stress is that no matter how blends are provided, you need to think about the nutritional content. So if they're on hospital food for a prolonged period of time, you might want to think about assessing the micronutrient content of them. If there's a limited selection of blended meals, it might also be beneficial to think about putting a patient onto a multivitamin to prevent any nutritional deficiencies as well. So introducing blends in a hospital is a big undertaking and challenge. And it's not just about the governance and food provision. It's also important to look at resources and training needs to help support staff. So research has shown that clinicians are willing to support blended diets, but a lack of training leaves them feeling unconfident. A survey of clinicians in Australia and New Zealand found that only 16% felt confident supporting blended diets, and 48% were unaware of the OSPIN guidelines or resources. And similar findings have been reported in surveys conducted in other countries. So what can we do to improve this? I feel that as clinicians, we're really good at translating the written guidelines into practical advice, but often we don't experience the practicalities. Therefore, it's really beneficial for us to experience preparing and administering blended diets to be able to guide patients, parents, and carers about the consistency and also help with any troubleshooting. I'd therefore encourage you to have a go at home or in your department using stage 1 baby food, some of which may need diluting, and administering through extension sets. You could also try making your own recipes to understand which foods can go into a blend easily and which ones need to be adjusted slightly. I've certainly found a lack of confidence around blends, and I've had to show ward staff how to administer them. But with staff on shift patterns, this has meant needing to show multiple people for the same patient, which probably isn't the best use of my time. Training videos for staff to access could be a way around this. And there is also a number of companies that have produced videos and further guidance on how to prepare blended diets. At Newcastle, we've produced ward packs for nursing and dietetic staff. So these contain information about the types of meals that are suitable to be ordered from the menus, how to administer a blended diet, and how to dilute the blends, as well as the nutritional contents. And the team at Glasgow have also reported using a similar method for further supportive information as well. So to conclude, I'm going to reference a paragraph from the BDA toolkit. The prospect of developing a system to achieve blended diet provision can be daunting, with many obstacles and barriers which need to be overcome. However, with evidence and clinical benefit and growing popularity, it would be advantageous for a hospital to assess if it is able to accommodate blended diet as a method of feeding. Successfully implementing blended diets in an acute setting relies on collaborative working, ensuring processes and procedures are standardized and documented in policies or guidelines, and making sure the method of provision is individualized to your trust or hospital. Thank you.
Fab. Thanks, Ruth. That was really interesting and also very practical tips of kind of getting things up and running. We have a few questions come in, and hopefully some more will come in as we go through. I had a question before we get onto that. I just wondered how long, in practical terms, did it take for you to kind of get your service to where it is now? I think we've been working to try and get a blended diet service sorted as an inpatient. It's been a really, really slow process, although we're finally there. Um, but yeah, how long did it take?
Honestly, probably a couple of years, I would
Mm.
say, from start to finish. As we kind of started doing it before any of the guidelines came in, really. So I think it probably did take a while to do. I think once the guidelines were in, it actually became a bit easier because it definitely gave you structure on where to go and how to do it. And the BDA toolkit, I know I'm a bit biased, but I think it does give you a really good gist on how to do this as well. So there's a big section on hospital blends. So I think, but yeah, it's not something that you can just do overnight.
Yeah, absolutely. And I suppose in addition to that, I forgot my question, so I'll get back to what my question was. So someone has asked, how do you manage the mess of diluting the pureed meals at ward level? Our parents' feedback is that it's extremely challenging to kind of not get blends everywhere in the hospital.
Yeah, it is really messy. So how we do it is that the food comes up from catering and gets heated up on the ward. So we've got like a regen system. So it gets heated up, and then we will use like a water jug. So we've got all of our patients will have water jugs, and we've got spare ones. So we'll use a water jug and just empty the entire meal into the jug, and then we'll add whatever liquid needs to be used to dilute it down, whether it be water or milk or even some feeds as well. So we'll water it down to the right consistency, and then parents will just use that to draw up from inside the jug of what they need, and then obviously the jugs gets cleaned. We mix it up with a fork as well. And that seems to work okay. But I always, whenever I'm showing anyone how to do it, I always go in with loads of paper towels because like even the syringes get messy and you just need to wipe out the syringes as well.
Yeah. And is that did the parents make it the correct consistency, or did the dietitians go in and do that?
So it's a combination. So a lot of the time we'll train parents on how to do it. So if they're starting it from scratch, we'll sort of show them sort of the consistencies. But that's where your little pouches and stuff will come in because actually it gives them a really good idea. Nursing staff can do it as well. So I don't know about you, Lucy, but I'm finding now that there's quite a lot of nurses that are quite confident in blends. I think because there's so many parents and the parents are just showing them how to do it. So often some nurses will do it, but a lot of the time it is the parents doing that.
Yeah, absolutely. I suppose because we've had a bit of an issue with the infection control, saying that the parents shouldn't be drawing up the blends, that has to be done by the nurses, or the parents do it in the parent kitchen, then it comes to the patient bedside, then the nurse delivers the blend. So it's a bit of a long-winded process. So, but it doesn't sound like your process is that. They can just draw it up at the bedside, make it the correct consistency and pop it in the gastrostomy, right?
Yeah.
Yeah. Okay, we've got another question from Shelley, lovely Shelley from Gosh. When giving blends down the NG tube, do you know what IDSI level you would need for different sized tubes? So, for example, if it was a 10 French, we don't allow blends down the NG tube currently. I understand the risk that you'd already kind of mentioned there, Ruth.
No, I don't think there is anything. I haven't come across anything saying you have to have this ITSI level. I think it's just the fact that it is a bit thinner. I think from my experience, what I've also found is that we sort of advise ITSI level 1 to 3, but actually when you look at what parents do, sometimes it's a lot thicker. And I just think, oh God. So there isn't really any guidance on this is what size tube you have, and therefore this is what the consistency should be. We give it through like gastrointestinal tubes, and so although it might be sort of like a 16 French tube, you've got a jejunal tube in the middle of it. So actually you're reducing down your French size automatically. And some of them need to be a bit thinner, but I would probably be saying it's still probably like an IDSI level two, maybe one or two. But I think you would just go back to, if you can't administer it easily using a syringe, then it's too thick and you probably need to dilute it down a bit more.
Yeah, should be relatively a bit stiff to push, but not
Yeah.
like so that you're putting loads of
Yeah.
pressure on it. Yeah. And with the blends, with your service, so do you give the blends to children who just are admitted, established on blended diet already, or would you start an inpatient that was admitted for, whatever reason, say a gastro patient that was there for a long term thing, or a short bowel kid who's doing home PN training, for example? Would you start blends on those patients as an inpatient?
Yeah. And we
Yeah.
have. If it's because we're a regional centre, we'll often get patients from sort of miles away. So sometimes we might try and speak to like local dietitians to make sure that they're happy with it. In our hospital, our consultants and surgeons are very pro blends, and actually sometimes I'm having to stop them doing blends in patients because it's not always suitable. I'm like, no, put your brakes on. No, we're not doing it. But yeah, we will also start it in patients that have come in and maybe aren't tolerating feeds, and we'll give them blends to try and help from that point of view.
Yeah, fantastic. Um, and you just use your hospital menu, hospital meals that you send up or get blended up and then sent up. Is that right?
Yeah, that is what is meant to happen. There is a few things that I have found out, and actually, our whole pathway needs a bit of review and a bit of an update, to be perfectly honest. But yeah, essentially, we use the ITSE level 4 and we water it down. We have had occasions where parents aren't happy using that and they want to bring their own blends in. When that has happened, what we've ended up doing is going through and doing like a risk assessment and sort of trying to come up with ways in which we can maybe cater for it as well. I think the main thing is making sure that you know when the blend has been made, how long it's been out, sat at room temperature, and how you're going to work all of that out as well.
Mm,
I think we've had it where there's been blends in fridges and like, how long's that been in for? And we've had to throw it because no one can tell us, just from a microbial point of view as well. So there is
yeah.
things that you really do need to think about with it.
Yeah. Okay. Excellent. Um, All right. Well, I think that was really insightful. Definitely, I think there's probably a lot of people be banging on the door for all the people they want in their stakeholder group as of next week. If anyone has any other questions, just do pop them in the chat now or in the question and answer box. But if not, then we will let everyone enjoy their evening and Ruth get home. I think you're still at the hospital, aren't you? Yeah.
Yeah.
Okay, all right. Well, thank you so much, everyone. You can watch this back on YouTube at any point if you need to kind of pick up on anything that Ruth has said. And I'm sure she won't mind, any emails coming her way if you have any additional questions. All right.
Yep. Fine. All right.
Thank you.
Bye.
All right. Bye-bye. Bye.